So moving on to the second part of the lecture for respiratory disorders this week. So just to recap over the lecture contents, and we'll be moving on to the pathology of asthma. But before we start on that, just having a look at the statistics with the incidence of asthma. So these statistics are provided by Asthma Australia. And from 2007 to 2008, 9.9% of the population had stated they actually had current asthma. So that equates to about approximately 2 million people in Australia who do have asthma that is currently active. So the prevalence is higher in people aged 75 years and over. So that's approximately 11% of the cases that are present in the population. And the reason that I had specifically put up that statistic is particularly if you are working in allied health, the majority of individuals you will be working with are elderly individuals or people who are, middle-aged adults. So it is important to keep in mind that when you are treating those who are elderly, just double check if they have had a history of asthma and if they do have the medication with them. So between the years of 0 to 14, it's actually more boys than girls who have asthma, but then from 15 years and over, it's more females than males who have actually, persistent asthma. The majority of deaths from asthma occur in people aged 65 years or over. The risk of dying from asthma actually increases with age. So again, tying in with the whole allied health, working with elderly populations, just being aware of those sort of statistics. So in regards to hospital admission rates, so for adults, it usually occurs within winter months. And again, if you have a bit of a background behind the pathophysiology of asthma, hopefully this makes a little bit of sense to you, but by the end of this lecture, it should make more sense. And occupational asthma is the most common occupational lung disease in the developed world. So with at least 9% of cases of adults with asthma either caused by aggravation by occupational factors. So if you do end up working in work cover, or somebody who does have persistent asthma attacks and then they do tell you about the nature of their work, please keep this in the back of your mind as well. Let's define what asthma is. So it is a chronic inflammatory disorder of the airways that is associated with the recruitment of inflammatory cells and the clinical development of certain symptoms. Now, before this, research actually thought that asthma was as a result of abnormal bronchospasms that had occurred within the airways. And there is a bit more to the pathophysiology than that. There is exacerbated bronchospasms, but it isn't just to do with the smooth muscle cells, which is why now it is more recognised, thankfully due to greater research into asthma, that it is a chronic inflammatory disorder. So these symptoms are wheezing, shortness of breath, chest tightness, and a cough. And it is also characterised by a variable airflow obstruction and airway hyperreactivity. As previously talked about in the COPD lecture, the biggest difference between asthma and COPD is that asthma is actually reversible with prescribed medication. Now let's have a look at asthma in a bit more depth. So it is a chronic inflammatory disorder, so then there are acute bouts of exacerbated inflammation, and this is during an asthmatic attack. And research has identified that there actually is over 100 cellular mediators that are responsible for the development of this inflammation within the bronchi. And the main ones that they have identified to promote this inflammation are by endophils and mast cells. So endophils, if you remember potentially maybe back to first year, endophils are your white blood cells, and these actually increase with any kind of allergy or infection. And mast cells actually play a very central role in inflammation, and they sort of immediately pop up during allergic reactions. Now, your endophils and mast cells then eventually infiltrate into the layers of the bronchi and then actually cause edema of that area or of the airways. So this actually then creates the swelling that comes with the inflammation of asthma. However, asthma isn't just about the chronic inflammation. So there is still this abnormal reactivity or bronchospasms with the smooth muscle cells that are in the actual airways. And we have particular chemical mediators. So your prostaglandins and your sinistyl lycotrienes, which actually contribute to this constriction in the airways. And then what happens also in asthma is that the airway lumen is then structurally changed, and then it becomes occluded by mucus. So the reason for that is that the particular glands in the airways then hypersecrete mucus due to the fact that they enlarge. And there's an increased number of goblet cells that actually contribute to this as well. There is also significant hyperplasia, so an increase in the number of cells, and hypertrophy of the airway smooth muscle, which actually then contributes to the wall thickness, making it a smaller, so if you can think about, again, sort of a hose, making it a smaller area for air to actually go through. So this in itself can then also contribute to the reduction or this changed airway that then essentially becomes more blocked. Naturally, with an inflammatory response, there is going to be some form of blood vessel dilation to the site to promote the blood flow to go there. And unfortunately, this obviously increases the edema at the site. So if we want to put this on top of the wall thickness, the promoted wall thickness due to the hyperplasia and the smooth muscle hypertrophy, you can now think that there is a profound change to the circumference or the diameter of the airway, and it's clear that there is a smaller sort of area for that air to now go through. And there's also proliferation of new blood vessels, so a creation of these new blood vessels. So it is done through the increased expression of vascular endothelial growth factor. If you don't really have a background in understanding cellular signaling and also genetic alterations in the physiology, this is sort of what this sentence is talking about. So that will be enough for your understanding for asthma for now. So airway hyperresponsiveness. So this is where we have these exacerbations, in particular with asthmatic attacks. Unfortunately, the mechanism is still not completely understood. However, it does lead to excessive contractions of the smooth muscle, thickening of the airway walls, and this sensitization of airway nerves. So this combination of each of these sort of symptoms or changes then results in an exaggerated bronchospasm. And we'll have a talk about what mechanisms or sort of triggers that we are aware of that do actually irritate the airways during an episode of hyperresponsiveness. So there are a few things that do provoke the inflammation that is in asthma. So we've obviously talked about certain cells. However, we have things called inducers. Now, inducers can be allergens, chemical sensitizers, air pollutants, or virus infections that then induce inflammation into the airways. But then what then happens is that we have some form of airway hyperresponsiveness if the inducers do provoke the inflammation enough, which then results in airflow limitations. So when we do have this airway hyperresponsiveness, remember we are starting to have contractions within the smooth muscle cells there in the bronchi. And as a result, we will then hear of symptoms such as coughing, wheezing, and any shortness of breath or dyspnea. And the worst thing that could happen for these individuals when they do get to the state of airway hyperresponsiveness is that they are in an environment or in a particular sort of situation where their trigger for their asthma actually evokes this even further, leading into an asthmatic attack. So triggers that then really irritate the airways at this stage can be allergens, exercise, cold air, or certain particles, so thinking about occupational-based workplaces as well. But there are some people who are particularly sensitive to dust, and that can actually set off the asthmatic attacks as well. Moving on to a bit more of an extensive list of certain triggers. So as you can see here, there is a bit more of a list, and I'll let you look at that in your own time. But the one that definitely concerns us the most is the fact that people can have exercise-induced asthma, which shouldn't be a surprise to most people. And it is really important that if you do have someone who is asthmatic, and particularly EIA, asthmatic, you're making sure that they have their medication with them at all times during an exercise session with you. And we'll talk about the procedures of making sure that that individual will be able to safely exercise. Having a look at the diagnosis of asthma, so much like COPD, there is some form of pulmonary function testing through spirometry. And we're looking at an obstruction through your FEV1 measurement, so your forced expiratory volume over 1 second. So that's decreased to greater than 80% predicted, plus looking at a decrease in the FEV1 to FVC ratio to less than 60%. However, remembering back that asthma is reversible through medication, we should actually see an increase in your FEV1 to almost greater than equal to 12% after the use of a beta agonist, and those are just a bronchodilator. Now moving on to medicinal-based management for asthmatics. I won't be going into too much detail behind the physiology with each one of these medications, but I will give you a brief understanding of how they work. So starting off with controllers, and effectively what they do is reduce the inflammation mechanisms. So your corticosteroids and your leukotriene receptor antagonists in particular target your certain cells, so particularly your endophils and your cystinoid lycotrienes. So remember that when they infiltrate into the airways, they actually cause edema at the site. Your inhaled beta-2 adrenoceptor antagonists are actually bronchodilators. So when we're talking about bronchospasms, there is bronchoconstriction as a result of that. And then clearly the opposite to that is dilation, where we increase the actual diameter and the circumference of the airways to allow for a greater amount of area for air to go through. There are two classifications of these bronchodilators. There's usually a long-acting and a short-acting bronchodilator. And for controlling it, just depending on how severe poorly managed the asthma is, controllers are generally seen in those who have had it for quite some time, or it is also poorly managed. So particularly if someone is on an inflammatory-based medication, you usually know that their asthma is usually quite bad, or they've had a few exacerbations or asthmatic attacks over the duration of the diagnosis. We also have relievers, so particularly relievers are super important during an asthmatic attack. And the main thing that they're trying to do is relieve bronchoconstriction or the bronchospasms. And as I mentioned before, so there's rapid-acting ones that very much target the specific beta receptors at the airway site only, and these are only to be used when they're needed. So we have anticholerogenics, which aren't seen as much in asthma anymore, more in COPD medicinal management. However, there's also glucocorticosteroids to assist in the management of the inflammatory response during those periods. We also have preventative medications. So the role for these medicines are to make the airway less sensitive, so to reduce the hyperresponsiveness, reduce inflammation, and reduce any sort of mucus buildup that can contribute to the blocking of the airway. So there's also short-acting IBAs that are involved with this and are usually inhaled pre-exercise, and that's the medication you expect them to bring in with them when they come and see you. There are also cromone medication, and we've talked about your LTRAs. However, cromone medications are mast cell stabilizers. So mast cells are also involved with the inflammation process with asthmatics. So you can see that there is also some form of anti-inflammatory medication that is involved with preventative drugs. So if you do want a more extensive list on asthma medications, I've got the Asthma Australia website list there, and it actually does give you a great extensive list with a great summarized explanation of what their roles are, which might be of more use to you when you go into postgraduate study. Having a look at AIA, so it's defined as asthma symptoms which occur during or after exercise. And it's provoked more in continuous-based activities or those played in cold weather, which are likely or more likely to trigger EIA. So remembering that cold air can contribute as a trigger to having to provoke more airway hyperresponsiveness. So symptoms usually begin 5 to 20 minutes after initiating exercise, and can actually peak 5 to 10 minutes after ceasing exercise. And because we need to manage these peak times where symptoms can arise, it is extremely important with these individuals that you do have a prolonged warm-up as well as a prolonged cool-down to just avoid any rapid changes of temperature that is going through the airways at those times as well. While it isn't really particularly mentioned in the exercise prescription guidelines here within the ACSM guidelines, it is expected that with the prolonged warm-up and cool-down that you are giving them at least 10 to 15 minutes to progressively get their body physiologically ready or progressively wind down their body back to a more resting state. In terms of aerobic strength and conditioning based stuff, as well as any sort of balance training. So if we are talking about younger individuals that you are prescribing exercise for, there's actually no reason that they shouldn't be exercising like any other healthy individual. However, keeping in mind that when you are first starting them out with exercise, that firstly, they've taken their medication before they come in and do their session with you, but progressively building up that intensity. So it always has to be a very gradual based session. So we have goals there, but the intensity and frequency duration that you're aiming for is an RPA between 11 to 13, monitoring any shortness of breath, 1 to 2 sessions, 3 to 7 times a week, and you're looking at about roughly 20 to 60 minutes per session. And a good idea is to start off with them being intermittent, because that's not a problem. It also will help them monitor their symptoms and for you to monitor their symptoms as well. And to be able to achieve all of this sort of goals, plus getting them to their exercise sort of requirements based off the guidelines, give them about 2 to 3 months. So remember with your exercise prescription, as I said previously in the COPD lecture, you are not expected to get them to 60 minutes from the get-go. Give it time. It is about getting them adjusted to be able to take on the exercise prescription to the best of their ability. Okay, strength training. So we want to increase, obviously, lean body mass and increase the max reps that they can achieve. But particularly with asthma, and if it is someone who does have EIA asthma, there is, again, this very big psychological component to try and break down the barrier of that, which again is why we do progressive, gradual-based sessions. So starting them off with a low resistance, high repetitions, quite achievable, and again, starting at a lower intensity, which can be incorporated 2 to 3 times of the week. And again, trying to get to those particular goals within the 2 to 3 month mark. Flexibility, so again, a very holistic based flexibility program unless there are particular musculoskeletal considerations that you should be incorporating into their program. So the aim is that you incorporate this daily, and it is particularly important if they are sitting around all day. And for elderly individuals, this is where the neuromuscular based stuff would be particularly sort of stressed, when we're looking at balance-based exercises, so to reduce the risk of falls there. But there are particular breathing exercises that you can look into to improve the efficiency of breathing for asthmatics as well. Having a look at the special considerations for the asthmatic patient. So when you are prescribing exercise, it's actually preferred to choose RPE as a method to prescribe intensity, but also even looking at their dyspnea scale. So with individuals who have a bit more severe asthma, I usually want them to be exercising no more than 3 out of 4 on the dyspnea scale. 3 is quite uncomfortable, and depending on how they feel, you might actually feel that that is too high of an intensity. Make sure that the patient has their asthma action plan on them at all times, and it is extremely important for you to be aware of what that action plan is and what medication is involved with that. Because if they're having an attack, it is up to you to try and obviously attend to them as best as you possibly can. So if it is possible within their sort of lifestyle and their time restrictions, try to get them to exercise mid to late morning because the air has started to warm up, particularly in winter months. The reason for that is that more humidified air actually doesn't trigger off the bronchospasms and the bronchoconstriction that is associated with the airway hyperresponsiveness in these particular asthmatics. And as another point, just make sure you avoid extreme temperatures, particularly low temperatures and low humidity, which is why actually swimming is usually a good exercise modality for these individuals if they like swimming. And if they do need supplemental oxygen, just make sure that it is adjusted to only desaturate to 90%. I've already discussed having a prolonged warm-up and cool-down for these individuals, but they can only exercise if they have taken their controller and preventative medication before your session. If they turn up to your session and they have not taken their medication, that's it. Like, you do not exercise with that individual. And always make sure that they have a reliever medication available with them, just in case there is a bit of an asthmatic exacerbation that does occur in your session. So it is okay if they do turn up to your session, haven't taken it, but give them time to take the medication and let it have an effect. But if they do turn up, no meds, no exercise. Here is just an example of an asthma action plan. It's color-coded, which makes it a bit easier for you, so in green, orange, and red. And clearly the colors signify the severity of the possible situations that the individual could be in. So green represents their everyday management plan with their usual routine. However, when the individual isn't doing too well, then we start moving on to the orange or red. So orange will explain what sort of dose the individual then needs to take or what type of medication they then need to take when they aren't doing particularly well on that day. And then clearly, if those particular symptoms get worse, what then becomes the sort of more aggressive action plan for that, which again will usually be just a different type of medication. However, it is extremely important to really have a look at your first aid training and how you need to then implement the 4x4 action plan for that if it does get to a severe asthmatic attack. Again, if you have any questions regarding the respiratory lectures, please send me an email. However, that's it for this week's lecture, and good luck with the quiz.